we are actually trying to read another organ to help read the organ of our focus. So we are trying to decode skin so that we can help decode the brain better. And we have a very erudite speaker with us. And one of our chairpersons is actually double MD. He is his dermatologist and psychiatrist. So let me welcome you to the 112th episode. Next slide, please. I'm handing over the session to Professor Dr. Tufan Pati sir. Sir is from Cuttack, chairman of this program and champion of this 112 session. Sir, over to you.
Thank you, Dr. Alim. And I have the pleasure to introduce Dr. Alim Siddiqui and Dr. Amrit Patujoshi, the vibrant, always vibrant moderators and the brain behind all this work. Dr. Amrit Patujoshi, Professor of Psychiatry in High-Tech Medical College, Bhubaneswar, and is a direct council member, now the President-elect of IPS Research Branch and Eastern General Secretary. Next one, please. Dr. Alim Siddiqui is Professor of Psychiatry in ERA's Lucknow Medical College. He is now the honorary treasurer of IPS, and he had been the direct council member earlier. He is Vice President of IMA Lucknow and Editor-in-Chief of Indian Association of Biological Psychiatry. Welcome, Dr. Alim and Dr. Amrit.
Thank you, sir.
Next, please. We have got equally vibrant chairperson, Dr. Adarsh Tripathi from Lucknow, additional professor of psychiatry at the King Just Medical College, Lucknow. He has got more than 90 international and national publications and 15 book chapters and few books to his credit. Research projects funded by NIMH USA, John Hopkins Medicine, ICMR are being conducted by him. He is EC member of Preventive Psychiatry or WPA. He is direct council member of IPS Honorary Deputy Editor IJP, Honorary General Secretary of IPS UP State Branch, Editor of Indian Journal of Behavioral Sciences, the publication of IPS Central Zone. His areas of interest include cognition and cognitive neurosciences, cognitive behavior therapy, human sexuality, and spirituality. He has got several awards and recognition. Welcome, Dr. Adarsh Tripathi.
Thank you, sir. Thank you very much.
Next, please, Dr. Saeed Akhtar is a veteran psychiatrist, a senior psychiatrist, and very renowned psychiatrist. And he has got double MD. He is MD in dermatology in 1986, DNB in psychiatry in 1988. He retired as deputy medical superintendent of CIP 2014. Currently, he is consultant psychiatrist in Dr. Said's Beautiful Mind at Baria to Ranchi. He is also consultant psychiatrist and dermatologist in Kanke, Ranchi, where he runs sequential OPD in 2 psychiatry followed by OPD in dermatology, perhaps rare in any part of the country. Welcome, sir, with a rare personality, with rare virtues and rare capacities, Dr. Saeed Akhtar. With this, I hand over the further proceedings of this meeting to Dr. Saeed Akhtar and Dr. Adarsh Tripathi. Anyone can introduce the speaker and another person can introduce the topic.
Saeed, please, can you introduce the Manoli, sir? Hello.
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 Yes, sir. Yes, please.
Adarsh, I think you introduced the speaker because
Adarsh, you can.
that is on mobile. So
it's my great pleasure to introduce the speaker. First and foremost, I would like to thank the organizers for inviting me on this prestigious platform on this very important topic. So to introduce Dr. Ravindra Monoli, who is hailing from Manipal, he is Associate Professor of Psychiatry in Kasturba Medical College, Manipal, Manipal Academy of Higher Education, Karnataka. He has won several awards, including gold medals for best outgoing post-graduation, Dr. S.S. Jairam Memorial Award for year 2014 for contributions toward enhancing public awareness in the field of mental health by IPS Karnataka chapter, Dr. M. Dhruv Kumar Award for Best Psychotherapy in 2014-15 by IPS Karnataka chapter, received 3rd prize for mental health literature in local language section, 3rd edition of SCARF 2015, prize winner at MAHE De Dallas Mental Health Hackathon 2022, He has 32 publications, 4 book chapters, and more than 80 newspaper articles. He is affiliated with the Indian Psychiatric Society as Life Fellow, IIPP, IMA, founder member and honorary secretary of Udupi Psychiatric Society, and founder member and past treasurer of Psychodermatology Association of India. Welcome, Dr. Ravindra Munali, for this talk. Over to you, Dr. Saeed, sir.
Hello, good evening, everybody. Hello.
Mr. Mondal, you can
you
stop
see me?
sharing the screen.
Yes, sir, we can hear you. Please go ahead.
हाँ, वो photo नहीं आ रहा है. I'm not getting my photo. Video, you're getting. Yeah.
Yes,
Good.
sir.
So, good evening, everybody. Thank you very much to Dr. Tufan Pati, Alim, and Amrit for inviting me to be the chairperson of this web seminar. I have been working as a psychiatrist and a dermatologist for a long time, and I find the relationship between psychiatry and dermatology very fascinating. Because the skin is a part of the body which is exposed to everybody. You can see the skin in all its length and breadth. And a small blemish can cause a lot of psychological reaction to you. So I have been seeing patients of dermatology, and I'm finding that people were having a lot of psychiatric problems with it. There are, in fact, already people have suggested that the skin diseases can be exacerbated by psychological factors. There can be some illnesses which can only be primary psychiatric disease, but which has a dermatological manifestation. So they are called cutaneous non-diseases. And the third are certain psychiatric illnesses which has got certain dermatological illnesses that has got psychiatric complications like depression, anxiety, and phobia and other things. So when there are a lot of publication on this, but I will be telling you all with my experiences. So what I see in India, that certain illnesses has got a lot of psychiatric implications like acne. And among the girl, the falling of hair in India is a very bad consequences psychiatrically. So people do come with falling hairs. And there are people with some vitiligo and acne, they come with psychiatric complication. Apart from that, some of the people which have primary cutaneous disease like delusion of parasitosis, neurotic excoriations, and nodulus, pruritus nodularis. So these people have got primary psychiatric illnesses, but they have got psychiatric manifestation. So when we call about the relationship between dermatology and psychiatry, and we try to find out whether the dermatological illness can mirror the psychiatric illness. So we would like to see some signs in dermatology we can diagnose psychiatric illness. For example, when we are seeing some patients with a lot of self-mutilating injuries, we try to diagnose as borderline personality disorder. Some people with tattoos of different kind and ear prick and other things, we think that whether they are suffering from some personality disorder or not. There are some people with a lot of excoriation, we think whether they are having some primary psychiatric illness like delusion of parasitosis, etc., etc. So we have, when you talk about, because I have seen a case, the patient is having perioral lesion, and there are a lot of people are diagnosing his perioral dermatitis, but I found that actually it was a habit of licking his lips again and again. And so I found that probably it was a compulsive act. And so with treatment with for OCD, the patient said lesions disappeared. So when we say about mirroring of dermatology, so I like to see that whether we can have some dermatological signs for psychiatric illness. So if you can deliberate on that, probably it will be very nice. I think with these comments, I can hand over to my co-chairperson for his comments and giving it to the speaker. Thank you very much.
Sir, we can start the presentation, I hope.
Okay, that's fine.
Thank you.
Okay. Thank you, sirs, for that generous introduction. I also thank Tofan Fatih sir, Alim Siddiqui sir, and whole team of Thursday Musing for not only providing opportunity to me to present this topic, but also to think about including this topic in Thursday Musings. Because since the time of pandemic, as I noticed, like many people attend Thursday Musings, even though the attendance is quite good number. It's an honor to be honor to present it here because being chaired by Psychodermatologist sir. We heard about you, sir, like being a dermatologist and being a psychiatrist also. So probably you have more experience than my age also in this field. Okay. So I would like to start my presentation. This will be just a brief outline of what I am going to talk about today. Psychodermatology. What we all need to be aware of, the conditions and the common psychopathologies underlying, and what to do in such scenarios. Since the audience is mixed, where we have mental health professionals and dermatologists also, many of them have joined. To begin with, where I work is in the Department of Psychiatry at Kasturba Medical College, Manipal. We run a liaison clinic or psychodermatology clinic in dermatology OPD. The clinic exists since more than a decade now. So where we have one designated day where all the cases which they seem fit to be evaluated under psychodermatology clinic, dermatologist will in those cases.
Dr. Ravindra, your voice is echoing a little. Can we just?
Yes, sir. How is it, sir, now? Is it echoing now?
Yeah, better now.
Okay, sir. So where we liaise with a dermatologist and a clinical psychologist also. So three of us see one person and we discuss and we come to a conclusion how comprehensively we can manage the person with the psychodermatology condition. So under this, we wrote a couple of articles. We formed an association also. We'll come to that later about those things. So what exactly is psychodermatology? This is one of the definition or one of the understanding, like what exactly we can think about it. A branch of medicine which addresses the dermatology or physiological changes in skin, in which psychosocial factors play a role in etiopathogenesis, progression, exacerbation, treatment, or prognosis. Further, it addresses all dermatoses in which psychological disorders can be seen as comorbidities, either as primary conditions or a secondary condition due to dermatosis, or as treatment emergent condition. And all of these will require comprehensive psychocutaneous approach. Either it can be assessment or intervention. So this was one of the definition given by me recently published in one of the articles. As the chairperson was mentioning about the skin and psychiatry, both exist together. One is visible, one is not at all visible, right? So that's how the difference is there. A little aberration in visible part can cause a lot of problem in the invisible part of the human. The psychological factor can act can have an etiological role in the absence of any real skin disease, or in pre-existing skin disease, these can exacerbate. Psychological factors can be a result of disfigurement caused by skin condition. So there is an interplay at various levels between skin and brain, or skin and mind, you can call it as. Various studies have mentioned, okay, so I'm not quoting because many of them have came to the same conclusion. At least 1/3 of dermatology patients have psychological or psychosocial issues which warrant to be addressed. If you look at incidence, let's say this is one of the older paper, 1978, but I still find this is quite relevant. The diagnosis, we have various dermatological diagnoses like hyperhidrosis, lichen simplechonica, rosacea, deciduous, etc. So proportion of them which get triggered with various emotions. Okay, hyperhidrosis almost 100% within seconds. Lichen simplex 98% within days. Commonly seen urticaria 68% within minutes. We will have trigger this. Psoriasis same. Papillary acne vulgaris within 2 days. So this indicates the dermatological manifestation which is visible is triggered by some emotional cause. However, we end up addressing dermatological condition, but we may not look into the psychological aspect. And why does it happen? Is it something like imaginary thing or anything? No, it has a biological basis that we need to understand. Since we talk everything like from embryology onwards, here also it's the same thing. The neuroectodermal layer during development, embryonic development, it gets differentiated. One gets differentiated as epidermis skin cells, pigment cells, then neurons of the brain. So that's how we can think of interplay between these two, how one can affect other one. If you go a little bit deeper into pathophysiology of it, stress lead to neurogenic cutaneous inflammatory response. Okay, so this will lead to some stimulation and products at nerve endings. We all know skin is innervated by sensory C fibers. Okay. The neuropeptides which are there are substance P and CGRP, calcitonin related peptides. So they're not going into those details. Stress activation happens at HPA axis. We know how stress can induce hormonal changes, neuronal changes, and neuropeptide changes, and sympathetic nervous system activation. All these will lead to skin mast cell activation, which can lead to various other inflammatory response. Immune suppression will happen, skin serotonin level will increase. Subsequently, we can see vasodilatation, you can see allergic skin disorder, etc. Stress alters skin barrier function also, so which makes it susceptible to cutaneous inoculation with bacteria, dust, or mites, etc. We all know stress delays wound healing in healthy individuals. If there's external wound, skin-related issue, let's say like urticaria is there, psoriasis is there, persistent stress, despite the best treatment, the wound healing may get delayed. Most of us have seen or we experienced during the exam times, all of us will have herpes viral infection around the mouth, or we have seen many students or many of our friends also having these infections. So that's how the link is there between. If you look at core psychodermatological conditions, various classification exists, but the classification which is given by Ku et al. And seems quite relevant and seems quite easy to understand and to follow. We can classify them into 5 main group of disorders, psychodermatological condition. Psychophysiological disorder, primary psychiatric disorder, secondary cutaneous sensory disorders. Then use of psychotropics for purely dermatological indications. We'll see one by one what exactly we mean by these, and certain conditions which may warrant little elaborate description and a little bit about how we can manage those. The term itself will indicate psychophysiological disorders. These are basically bona fide skin disorders. Here, the skin disorder is exacerbated by stress, as I mentioned about the various neurocutaneous or hormonal mechanism. It includes atopic dermatitis, psoriasis, acne vulgaris, seborrheic dermatitis, deciduous. So even these are these people are further classified as stress responders and non-stress responders. Okay. So where there is a close and temporal relation between stress and exacerbation of skin's condition, which are mentioned above. Okay. At times, those may not have response to stress. Okay, so let's say atopic dermatitis stress responder, psoriasis stress responder. So that's how the relationship exists here. Primary psychiatric disorders. So this is a little bit broader classification where we see factitious disorder or self-inflicted dermatitis. We have dermatitis artifacta, malingering, etc. Dermatosis as a result of delusional illness and hallucinations, as Akhtar sir was mentioning about delusional parasitosis. Bromidrosis is also there, hypochondriacal delusion and body dysmorphic delusions, where the patients either visit the psychiatrist or the dermatologist. Somatoform disorders we have in psychiatry in similar manner we have in dermatology also, where there are unexplained cutaneous symptoms. At times, the manifestations may be because of our primary psychiatric disorders like OCD, etc. We'll see one by one. Factitious, we know what DSM tells about it. Participation of physical or psychological signs, either by self-infliction of the injury. There will be some deception. Okay, person presents himself to others as ill or impaired. Okay, so at times it will be obvious and we may tell like there is some malingering or the person is expecting some reward. There may not be other cause for those. Okay. Dermatitis artifacta. Here the patient himself or herself is causing problems to skin, hair, nails, scalp or mucosa. At times can be seen in people with subnormal intelligence also. Usually seen in children from age onwards. Okay. In early age group, the female predominance is seen almost 3 times to males. Even in adults, female to male proportion is higher. It may follow a major life event also. There is a temporal correlation which many studies have mentioned. There are clinical physical signs which are specific to this. And there may be some fabricated story which may. Usually patient describe that I was perfectly all right, doctor. Suddenly one day I had like so many lesions over my skin or over my face. There won't be any complete description of how individual skin lesion has happened. Okay. Usually these are on the accessible parts of the body. Face, dorsum of hand, forearms, frequently on non-dominant limb. Okay, because the dominant limb will be used to inflict this. The lesions will not fit in most of the lesions which are described for dermatological conditions. They may be polymorphic, which means various shapes, various sizes, and bizarre, clearly demarcated from normal surrounding skin, and can resemble many inflammatory conditions also. Let's see. Okay, here you can see crude linear angulated destructive factitious dermatitis in first figure. Other one straight edges and sharp angulation of lesions, so which will not be typical of any of the dermatosis. Okay. So that's when we get referral from our colleagues or friends, so that this is what is happening. You see the drip sign, okay, where you can see the lesion is there and there is a vertical thing which is something like dipping there. Wound after surgery, it's not healing. There is a central hemorrhage because it is an interference hemorrhage, what is being called as. Clinical variants can be plenty. As Akhtar sir was mentioning about cheilitis, where the person will have tendency to bite the lips. Okay, so or repeated lip sucking. It can be part of OCD also, it can be part of subnormal intelligence, or it can be part of even schizophrenia also. We have seen that's happening. And factitious nail disease we have seen hair artifact. Okay, then delusional disorders. Witchcraft syndrome is nothing but delusional thing. Okay, so there are plenty of varieties which we can see. So basic thumb rule is if it is not typical skin lesion, then by default it has to be something to do with psychiatric condition. The person may present something like this. He will tell like I have this skin lesion. Person may apply glue to the face and all, which may mimic a herpes zoster infection. Okay. Diogenes syndrome. Okay. Then we know Munchausen syndrome and Munchausen syndrome by proxy, where the illness in the child is fabricated by the parent. Usually the mother gets the child like, okay, doctor, this is what is happening. My child has bruises over the thing and nothing, we didn't know why it's happening. Okay. So there are various variants in this in Munchausen by proxy. The dermatological manifestations are also there. Okay, so we need to be mindful of these things also. So usually we get referral when the child is being brought by the mother with a skin condition which is unexplainable. So we need to look for this. Common thing, we also see dermatologists will see more than us this condition. Okay, delusional beliefs, parasitosis. Goes by various names, egg-borne disease, parasitophobia, monosymptomatic hypochondriacal delusion, etc. As we all know, person believes that he or she is infested with a mite, parasite, insect, whatever. They will have elaborate description how this is there, how it is moving inside my scalp, here it is itching, biting, burning, it is crawling under my skin. Whether it can be at some part of time of the day or some part of the day. Usually they may try to pluck it out from the skin. Okay, they will bring it in either a box or common thing is matchbox sign. I hope we all know about it, where they put that skin fragments and put it in matchbox and get it to us. See, doctor sir, ये देखिए, this is यहाँ पे कीड़ा था मैंने निकाल लिया अंदर there बहुत सारे अभी भी हैं. They'll tell you there are many other insects which are there inside. Okay. They even go on to describe they have laid eggs. One of my patients went on to an extreme where he felt like tobacco may kill it. So instead of ingesting tobacco, he used to rub tobacco to the whole body, raw tobacco. Another person went on to extreme that he wanted to kill the insect, then he would put his scalp to the fire. So at time, so he was admitted in plastic surgery following burn of the scalp. Okay. So this, but the illness was this parasitosis. Okay. These are certain some of the diagrams where the person described and they tries to pick the skin. Usually either they may get in some these sort of boxes or usually the matchbox because it is easily accessible for we Indians. Another thing, olfactory reference syndrome or olfactory delusion or bromhydrophobia, cacosmia, there are phantosmia, there are various names which you go through the literature. Predominantly seen in males. Unlikely, many a times it cannot be an independent condition. It usually is comorbid with depression, OCD, or it can be an organic condition many times. Okay. So differential diagnosis need to be kept in mind while addressing this. It can be part of temporal lobe epilepsy, Parkinson's, or at times brain tumor also. Here the person feels that there is a body odor coming out of me. Okay. So if a person who is walking in front of me just touches nose, he gives an explanation, probably my body odor was there, that's why he did that gesture. They may at times tell that the odor is coming from my neighbors or my mouth or my ear, etc. Okay. And as mentioned, it is predominant in male. Another condition, which consists of crawling, stinging, and biting under the skin. They come up with the sores that are not healing. Okay. Fiber-like filaments, granules, and crystals that appear on or under the skin. They will come up with the joint pain, etc., fatigue, also cognitive dysfunction, poor concentration, memory. The person will visit most of the departments. He goes to medicine, he goes to dermatology, he goes to neurologist, everywhere. Okay. Obsessive compulsive behavior. I'm not going much into detail of this. We all know about the washers, etc. This is just a photo of the person who went to dermatology with, like, see, doctor, my hands have become like this. There are dry skin and all the things which are happening. Basically, the issue was with OCD, where the person has obsession of contamination, the compulsion of washing. So fortunately, luckily, they found out this is related to this, then they referred, then intervention was done. After this was a change. Body dysmorphophobia, okay, where the person is not satisfied or believes that the either particular body shape or the skin color isn't okay or isn't satisfactory or isn't adequate or isn't acceptable by the society. Lichen simplex chronicus and nodular prurigo. Simply, we can understand this where there is a regular rubbing and pressure on the skin, which produces characteristic thickened, coarsely grained papules and nodules with hyperpigmentation. This we can usually see in most of our psychiatric patient, chronic, usually patients with chronic illness. We have seen few those who are staying in rehabilitation center. We have seen in children or in people who are staying in facilities for people with subnormal intelligence. Again, these are seen in areas which are accessible to persons. Knee points, sides of necks, elbows, thighs, knees, ankles. Another common condition is scrotal skin lesion. Here the lesions will be in varying stages of evolution. From early small vivacious papules with surface excoriation to chronic areas, which can present as hyperkeratotic plaques. Okay. These are described as dermatological worry beads also. We have many names to remember here, okay, beginning from matchbox sign, etc. Lichen simplex chronicus. You heard of trichotillomania, right? So similarly, we have skin picking disorder or dermatotillomania. The term itself will indicate the person will be picking skin repeatedly. The visual tissue damage and functional impairment. Okay. At times, lesion may extend till dermis also. Older lesions will show pink or red scars, some of which may be hypertrophic also. Chronic lesions will have atrophic scar. Why this is important to notice as psychiatrists is if we are a little bit aware of these things, we will be able to address these issues also. Acne excoriae, quite commonly seen in adolescent girls, especially under emotional stress. Again, it's just a variant of skin picking disorders, okay, where the lesions are largely confined to the face, around the hairline, forehead, preauricular area, and chin areas. Trichotillomania. We all know about this, where the person will get an urge or there is some discomfort at the hair root. Okay. Then the tension or anxiety builds up. Okay. Then tries to scratch, then pulls the hair. Pulling off the hair will give a pleasure, gratification, or relief, whatever we call it as. Okay. Many times it can be an independent entity without being part of anything. Okay. So there is discomfort provokes marked distress to the patient. It will be visible. Okay. So this condition we get to see in our liaison clinic. So how to identify, how to differentiate from other conditions? Simple. Short, irregular, broken, and distorted hair. And hairs will be in different stages of growth. Plucking activity is centrifugal from a single starting point or linear or in a wave-like activity. At times, these people, when they pluck the hair, they may ingest also. Swallowed hair, what will happen is it doesn't pass through the intestine because we have folds in gastric mucosa. They starts getting piled up there. Okay, they gets retained there, then they will pour a trichobezoar. We all know this. So it will grow like a tail further, which we all know it as Rapunzel syndrome. These are some of examples. Okay, first one is trichobezoar extending into pylorus. It's an endoscopic image. Other one is Rapunzel syndrome. We have quite a few case reports published some other in various journals. Okay. Next, we'll look at the secondary psychiatric disorders. As I mentioned, psychological problems as a result of having skin disease. As sir was mentioning, the visible part, a lot of stigma which exists, like even if there is a single white patch on a person's body. Okay. So it can be a psychiatric disorder, can be a comorbidity, or it can be a reaction to dermatosis because of disfigurement, discrimination, social isolation, stigma. So invariably, if there is any skin white patch, people will keep the person away, or they think that it is contagious. The person is unkempt, he doesn't take bath, he's unhealthy, or the person is boring person because he had literally got so many girls come with that thing. But the person has alopecia, then he's not considered as an active or the person to go ahead or mingle with. At times, the psychological problems or the skin problems can be treatment emergent also. Medications and the psychological adverse effect we can see. Okay, we know many antibiotics can lead to problems, steroids can lead to problems, which are used in dermatological practice at times. Antihistamines can lead to certain psychiatric problems. NSAIDs, antivirals, the drugs used in treatment of leprosy or the tuberculosis or psoriasis, they may cause certain psychological problems. So which they will be mindful of and they will always look for it and explain it and refer it. That's one good thing. Then we have cutaneous sensory disorders. Unpleasant sensations on the skin such as itching, burning, stinging, crawling, writing. It's just like what we have in somatoform pain disorder or somatoform disorders. Unexplained, let's say the pulling sensation is there. Unexplained burning sensation of scalp, unexplained pain. Okay. So these can be called as dermatological equivalents of chronic pain syndrome. It may have some psychiatric findings, it may not have psychiatric disturbance also. Pruritus, doxepin is one medication which is commonly used, okay, or amitriptyline can also be used. Psychogenic pruritus, very common condition, okay, though poorly defined entity, but commonly seen entity. So the person has intractable or persistent itch, not ascribed or not because of any physical or dermatological illness, but there is an itch. Okay, there is a itch scratch cycle. We all know that. Where the person gets an itch, then scratch feels better. Okay, then again it is like a conditioned response. So if the itch starts, scratches feels better. So it starts giving a reward. So the cycle goes on and on. So that needs to be broken in the therapy. The diagnostic criteria, we have this 3 compulsory criteria and additional criteria. Localized or generalized pruritus, it should last for more than 6 weeks, and there shouldn't be any demonstrable cause. Okay. Additional criteria will include there should be some life event associated, there should be some variation in intensity, nocturnal variation. Predominant should be there during rest or inaction. When the person is not doing anything, then automatically he will start scratching somebody. Further subtypes are there: compulsive type, impulsive type, and mixed type. Okay. Compulsive type, skin excoriation is performed to avoid anxiety or to prevent a deadly event. Okay. Impulsive type, it is linked with arousal or pleasure or reduction of tension. There are certain people like when they start reading, they will start scratching their forehead or the thing. Or it can be both types also. Though many may not come to clinical condition, but when they come is when the some partner or somebody tells that okay, there is a discoloration, there is lesions, etc. Then they come for treatment. The episodes are unpredictable with abrupt onset and termination. Okay, as I mentioned, occurring mainly at the time of relaxation. Again, the areas which are accessible to the person, only those areas get scratched commonly. Okay. We may find some psychological stress. Okay. Mentioned about using pharmacological agent for the treatment of dermatological conditions in the absence of any psychiatric disorders also. We use psychotropics, okay. In dermatological conditions, we use them for comorbid conditions also. Let's say, take the example of doxepin. It is more powerful antipruritic effect when compared to traditional antihistamines. Okay, it's available in oral form and topical application form also. Post-herpetic neuralgia or pain, amitriptyline is still a good choice. Okay. So when we are looking from psychodermatological point of view, so first thing we need to look at is where I can fit in, okay, among these 5 categories. Okay. So that gives us an idea to have a comprehensive overview of what it comprises of. Then comes the second step, okay, to ascertain the nature of underlying psychopathology. Let it be any of the disorders, psoriasis, atopic dermatitis, etc., trichotillomania. Okay. In dermatologists, okay, at times straightforward cases they will be able to easily pick up when the person is depressed or suicidal or anxious. When we identify it as a first step, we put them in any of the 5 categories. When we look at psychopathology, most of them will fit into only these 4 categories. Either person can have underlying anxiety disorder, depression, delusion, or we have put obsession compulsion as a separate entity. There is substance use disorder also, but still these are the commonly seen things. Okay. So underlying anxiety leading to certain problem, depression, delusion. So first step is for putting them in 5 categories. Second step is looking at underlying psychopathology. Okay. Psychological factors which can affect medical condition, atopic dermatitis, psoriasis, stress, anxiety. So we'll see many of correlation between these things. Okay. Chronic pruritus, depression, delusional parasitosis, it can be associated with other medical conditions. Okay. So now comes what to do now. Now I know about psychodermatology. I have put them in one of the 5 categories. Now I know underlying anxiety or depression is there. Now I put a major dilemma, which is a dilemma for dermatologists also. Okay. To psychiatrists, they may not come directly. Let me be very frank. So no skin problem person will come to psychiatrist straight away. Okay. So dilemma will be for dermatologist whether I should start some treatment or spend some time for therapy, or what should I do? So basically what we recommend is first, let's start discussing about it with the patient. Have a good rapport. Instead of spending 5 minutes, call the patient again and spend half an hour or so with them. Have a separate file for such patients where we will elaborate description can be there for the symptoms or lesions or life events or family history, like what we get. Then liaise with the psychiatrist, that may be better, or any other mental health professional. Then try to address the biopsychosocial model of whole illness. And the person should be made aware that to look beyond the somatic concept of disease. Skin means only skin only is the problematic. No, there is something else which is affecting skin also. Can start with brain. Can start with what we do is usually start with the model, how the embryological development happens. Ectoderm is there, one part, I simply tell them one part grows as brain, another part grows as skin. So that's how they are linked. If there is a problem in one, another will also get affected. Most surprisingly, most of patients are comfortable with this explanation and accept the treatment is being given. Okay. As I mentioned, most of them or outcome or the problems related to stress. So how that can be managed can be talked about. Then comes the part of role of psychotropics. There is a dilemma whether to prescribe or not to prescribe. Many may accept, many may not accept. Even there will be our prejudice or the pay attempt, like I come for skin condition, you are putting me this antidepressant, why should I take? Okay. So that can be sorted out by clearly explaining biological basis. To whatever extent they understand, let them explain how hormonal neurotransmitter changes can happen, how they are causing certain skin conditions or worsening existing skin condition. Okay. Further a step ahead, dermatologists and psychiatrists can liaise and explain it that for particular skin condition, available treatment options are used. Despite that, the lesions are getting exacerbated or not resolving completely. So that's why you may have to take the next step. Okay, ultimate goal is to cure the patient. Mainly antidepressants, antipsychotic, antiepileptic, some opioid agonist and antagonist, and of late N-acetylcysteine is making big wave in dermatology. Okay. So role of antidepressant, where all it can be used. Okay. Can be used in artifacta, para-artifacta, or skin picking syndromes, acne, excoriae, compulsive disorder, psychogenic pruritus, and somatoform disorders. Okay. So as I mentioned, though we have names these, underlying psychological aspect needs to be addressed, so that automatically will take care of other things. Let's say if there is an underlying anxiety that can help in artifacta, para-artifacta. There is a repeated hand washing or trichotillomania. SSRIs are useful. Still, what we are using for trichotillomania is fluoxetine, which is giving a fantastic result for us. Somatoform disorder, doxepin is there, amitriptyline, we are using amitriptyline predominantly. There may be secondary psychiatric disorder due to dermatosis, have to be treated as they are. Okay. Then we need to treat the psychiatric manifestation secondary to treatment. Isotretinoin. Good thing is all the dermatologists will specifically look for depression and suicidality while giving treatment. So we can liaise with them and manage accordingly. Antiviral, steroids, dapsone, etc. So antidepressants are indicated in these conditions whenever there's a occasion. Few more slides I will tell. So about doxepin mainly, because most relevant and commonly used is in dermatology. That's what I came to know due to its H1 and H2 histamine blocking activity. Almost first line off-label treatment for neurotic excoriation, generalized pruritus, and chronic urticaria. There's a topical formulation is also available. There is a good evidence for this. Okay. So there's one study which is done on retrospective cross-sectional study of 20 years duration, okay, which has showed improvement. Then with chronic urticaria also, it has shown good improvement. Then in patients with atopic eczema and moderate to severe itch, again, it has shown good improvement. I'll just skip this lot of statistics. I don't want to. Further, the sedative effect of doxepin can be used for the benefit of patients, because most of them will complain, sir, doctor sahab khujli hota hai isliye main so nahi pata. So we can give it to for the benefit of the patient. Okay. Another thing which we are using commonly in our center, metaz. Okay. It antagonizes adrenergic alpha 2 and heteroreceptors as well as 5-HT2 and 5-HT3 receptors. We found it to be useful in pruritus, okay, due to malignancy, cholestasis, renal failure, atopic dermatitis, and even in neurotic excoriations. It gives fantastic result for us. Even with the low dose, 7.5 and up to 15 milligram, we use up to 15 milligrams in dermatological conditions and a good response. And there's a good evidence available for this. So studies, I will just skip these slides. Then I mentioned about opioids. Okay. when they are not responding to these things, at times the naltrexone and naloxone, these are also used. But per se, personally, I haven't used naltrexone for any of the pruritus. We restricted ourselves to the previous ones only. However, there is evidence for these also. The role of antipsychotics in dermatology, we all know, retinal parasitosis. Then at times when we find there is a bordering between neurosis and psychosis at times, so there we may use. Can be used in trichotillomania also, pruritus which is not responding, dermatitis artifact also. Okay. And very rarely for hyperhidrosis. And we'll just skip this one. This is from one of our publications. Anti-epileptic, we know they can be used for neuropathic pains also. So even for pruritus, gabapentin is found to be useful. Okay. Yeah, though we have not used even topiramate, pregabalin. So these also can be used for the pruritus which are not responding to other medications. I mentioned about N-acetylcysteine. We are using it for cannabis or the radiation or as an anti-craving agent, but it's being used in skin for various conditions. Okay, for trichotillomania, acne, excoriation disorder, or nail biting behavior, ichthyosis, sclerosis, 10 that is toxic epidermolysis necrosa, atopic dermatitis, pseudoporphyria. So there are plenty of conditions for which it is being used now. Okay. Okay. So when we start treatment and all, probably we may have to do a little more for the patient, not only just giving medicines. Patient has to be made aware that it is not some rare case or anything. They need to know the link. Okay, as I mentioned in the first slide, there are almost 33% of the dermatological conditions have psychological issues. Okay. Disease is unpleasant but not dangerous. That person has to understand. Help and treatment available and it is successful. Okay. To conclude, it's quite a common condition. Though we just look at from our psychiatry aspect, many of the patients are seeking help in dermatology. Probably liaising with them is going to help us a lot. It's not something which is hypothetical or just in a hypothesis. There is a biological basis for all the changes which are happening. Okay. In addition to other psychological and social aspects, we need to understand those clearly. There's a lot of literature which is evolving from the West and from India also. A lot of papers and books have come up now in this area, which help in classifying and understanding them in a better manner. Liaison clinics are the need of the hour. We need to have liaison clinics with dermatologists at least once a week, okay, wherever there are facilities or medical colleges, or the people in private practice can try to liaise with the dermatologists. So the better healthcare delivery for our clients. Approach can be just quite simple. First approach is where we can put them in those 5 categories. Next, what's the underlying psychological issue? If we have grip on those things, we can plan management effectively in liaison with dermatologist and clinical psychologist also. Medications have good evidence. Okay, no need to hesitate or no need to feel bad, or person may feel like, why I'm giving a psychiatric medication. Explain it clearly and firmly and confidently go ahead with psychotropics for purely for dermatological conditions also. Okay. So the last 1 or 2 slides, I will just tell about this is a website of our association, Psychodermatology Association of India. Okay. And it has psychiatrists, dermatologists, and clinical psychologists also. Interested ones can log in and become members. In Jan 21-22, we have national conference in Calicut. So those who are interested can attend in these 2, register and attend. So concluding slide, I would like to thank Professor S.D. Shanai, currently who is a professor at Mangalore. She was with us for many decades, and last 1 decade I worked with ma'am. She's a dermatologist. Currently with Dr. Smita Prabhu, dermatologist. Dr. Savita Soman is working in the clinic with us. Dr. Shweta Rai is a clinical psychologist. Dr. Srijan K, the initial person who was with the liaison clinic, now is in Australia. This is one of the handbook of psychodermatology written by us and others who are working in this area. This book came up almost 7-8 years ago. I think it's available. With this, I would like to conclude my presentation. Okay. Thank you.
Thank you so much, Dr. Ravindra. Nice presentation.
Thank you, sir.
Over to chairpersons for their opening remarks.
Sahi sir, are you? So till Sahid sir join, Dr. Monali, thank you very much. It was really very comprehensive presentation, and you included almost all aspects related to psychodermatology. And as participant might have connected with it, that they do see a lot of cases which occur at interface, and some of the cases which directly relate to us. So it has been very useful listening and understanding some of the common management strategies. Although the time was limited, but there are several other aspects in this relation. Just to mention that the medications which we uses also has a lot of cutaneous manifestations.
Yes, sir.
Very benign manifestations from cutaneous hyperpigmentation to causing itching and pruritus and FDR and
Yeah.
Steven-Johnson syndrome or
Yes, sir.
epidermal necrolysis. And I have experiences of my own patient developing toxic epidermal necrolysis with carbamazepine. So one of my difficult to forget experience of the life in my early career of psychiatry. So we do come across such sort of thing. So updating knowledge in this regard, keeping abreast of knowledge is very important, and all the best for your newly formed association. I hope that this will be very useful for psychiatrists and dermatologists in India.
Yes.
Thank you very much. Yes,
Thank
Said,
you.
over to you.
Akhtar sir, your comments, please.
Yeah. I think it was a very nice presentation and very in simple language, and he tried to put everything in pressure cooked manner from etiology to treatment and other things. Probably it would have been done in many parts. But what I, as a clinician, my idea was that if somebody comes with a dermatological lesion or problem, you can immediately think of some differential diagnosis in psychiatric illness, because some patient come with lot of fungal infection in the hand.
Yes, sir.
So I immediately see that probably this patient is maybe OCD, washing compulsion.
Yes.
If somebody comes with capsulitis is a spot or sagging patches, we think about it as tuberculosis, sclerosis, and probably it may be patient may have autism, because we have seen a lot of autism in this person. So we can think about that. If somebody comes with seborrheic dermatitis, we think whether the patient is also having Parkinson's disease or not. If somebody comes with tattoos and self-mutilating things, we are thinking about the borderline personality. So
Yes.
this perspective may also be added
Yes, sir.
as a clinician.
Yes, sir.
So we immediately come to, because in the clinic we can just shortlist whether what may be the psychiatric differential diagnosis of this case. Nail biting.
Yes.
Some patient come, then thumb sucking. So you see hand and say, oh, this person may be doing some thumb sucking. So there may be some neurotic reasons for that. So
Yes.
that may shortlist our
Yes.
differential diagnosis through. So what I was thinking, that you were thinking reading skin may read brain. So that was a misconception, that probably you were talking about this, but you were talking about the general
Then
uh, general
psychodermatology.
textbook
Yes.
presentation. It
Yes.
was not a really that clinical presentation that I wanted to see. So if you are very expert in that, probably you would have done that. So that
Yes.
is my conclusion, whether you like it or not, but probably
Yes.
it would have been better.
Yes, sir. Actually, the focus, the neurocutaneous markers and the things. So actually, since we are seeing clinically, and most of the clinicians are aware of that, so
Mm.
we try to focus on certain area which is
No,
totally
that's
business
fine. I
topic.
think it
So
was good for the
that's why we just
psychiatrist to know about the dermatological condition. Yeah, sure.
stayed away from that, and also the audience is mixed because most of the
Yeah,
dermatologists
I know. I
are attending.
understand that. I
Yes, sir.
understand that. That is my perspective was that probably.
Yes.
So that's fine. Your presentation was
Yes, sir.
very nice. Yes,
Thank you, sir.
I appreciate that.
Thank you, sir.
Okay, thank you. Mm.
Yes, sir.
So if you permit us, we'll take some questions.
Yes.
Salim bhai,
Please go ahead.
I have a question to Dr. Ravinder.
Yes.
I see a lot of patients who complain, on SSRIs basically. There's discoloration of the face, the hands, OCD patient, you have no other option. You have to give a fluoxetine or maybe a fluoxamine. And I see severe, discoloration. People tell in 2 months I become black, I have become dark. And, adding to the discomfort a patient has of looking bad, looking black, and everybody commenting what medicines are you taking, it is making you look so dark. How do you go about, do you see, you have done a lot of work on all this. Have you seen these reactions to SSRIs?
Yes. Related to SSRM, fortunately, we have not come across so many with skin discoloration or anything. So the primary goal is to control OCDs. So when we are giving medicine, at times we may tell that the probable adverse effects are these things. Then if there is a discoloration or etc., then we take help of dermatologist straight away. So what else can be done? Because medication for OCD is essential. If you look at the other options which are available, but if the person has, let's say, responded well to fluoxetine or fluoxamine, I don't want to change it to something else if the person is responding well to that. So if there is a certain skin manifestation which is happening, so we need to take help of the dermatologist, like how best it can be managed. That's it.
Akhtar sir, my teacher is there.
Yes, sir.
Can you just throw some light, because I think it's a common thing I see.
I don't think that the SSRI can cause. I have not seen cases of
Yes, sir.
discoloration with. I thought it is only because of exposure to water and soap and other things that probably there may be some latent lesion or even fungal infections. It is not because of the SSRIs.
Mm.
So if this is there, then if there is eczematous lesion or the same lesion,
Do a
we can
case
treat it.
series. I
Look.
have to do a case on this, sir.
You can have seen, but I have not seen yet.
Akhtar sir, you were talking about tattoos. I think what we are now seeing, tattoos are in quite in very well adjusted normal population. So
I'm not telling, because I had been to Australia, and in the drug detection unit I worked there, and a lot of people were coming with tattoos, and we are finding that most of them had a lot of personality disorders. So it is not the sign qua non for borderline, but yes, there may be indications that you can think about that, and so do a differential diagnosis on that.
Amit, please beware.
Be aware. Be aware.
You have done also a tattoo on you? Okay.
You might get a spot diagnosis.
We have to do a differential diagnosis on that also. Okay. Thank you.
Okay. Okay. Ravindra bhai, how should our practice as a psychiatrist change because of our increased knowledge of dermatology?
So first and foremost thing is most of our patients, especially the chronic patients, a lot of dermatological issues which we never look into. Let's say beginning from skin fungal infections. Okay, so various itching related And to most of the chronic patients, we never do genital examination, but we found like almost 30 or 40% of them will have fungal infection. Then just like what we have somatoform disorders, those people will also have pruritus, which is quite commonly seen in this. So probably in addition to asking about the existing psychiatric thing also, we may go a step ahead and look for clinically we evaluate and ask questions also related to basic things about the personal hygiene, or is there any itching in, especially for chronic patients, is there any itching in any part of the body? OCD patients we treat, but we may have to look at whether there is any skin manifestation also, which is there, which warrants an evaluation and intervention by dermatologist also. So, and substance use disorders, again, skin lesions are quite common, that also we may have to be looked into. So,
Yeah, thank you, sir. Any comments on psoriasis and stress, and how is it correlating?
yes, sir. Psoriasis and stress, there is a literature. Urticaria also, there is a literature. So stress getting exacerbated because of, I mean, psoriasis getting exacerbated or relapsing because of the stress-related things, which are quite common. So many times it is under control. Then with the existing medication, there are exacerbations which are seen. So then we try to look at why it is happening. Is there any life event or anything has happened? So we try to make them aware of, okay, this is the issue probably that needs to be addressed to control the dermatological condition also, sir. So
in approximately how, a very rough estimate, in how many patients of psoriasis would addition antidepressant help? In 1%, 50%, or any your personal guess, I think, not a data.
not exactly data, but the people when they are not responding well to the traditional medicines or the found, so almost just like a response to our antidepressants. Let's say
Alim, you are asking a MCQ question or what? How many percent patient probably it is not a the data are this is not an MCQ 34% responded to. I don't think it should be asked to the presenter.
Large scale studies may not reveal that sort of figures of the personal experience.
Okay.
Yeah, only the personal experience we can tell, like, okay, out of 10, 4 or 5 might have responded, others might not have responded, something like that.
Okay.
One question is also a few questions already answered in the presentation, like pathway of doxepin in managing.
Yes.
Which is asked about naltrexone. Yeah, so those are answered already.
Yes.
One big question is there. Can I put it? 50-year-old post-menopausal lady, 40 kg, small stature with delusional parasitosis, evaluated by dermatologist, neurologist, gynecologist, complaints of itching, biting, crawling sensation all over body for the past 20 years, exacerbated past 1 year, referred to psychiatrist. Tried up to risperidone up to 6 mg, duloxetine 60 mg, no change. Tried clozapine but not tolerate medicines. Now started on mirtazapine and flupentixol. What is the way forward if that too fails? No stresses identified till now.
Sir, for delusional parasitosis, we got good response with pimoside, sir. So 1 or 2 milligram of pimoside. So almost like 60 to 80% of the people who came up with had almost remitted, and there was some relapse in 1 or 2 patients also. Then added pimoside again, so we got a good response with that. So probably pimoside can be considered, I believe, here.
And should dermatologists prescribe antipsychotics?
Yeah. What would you talk
Why
about?
not? Why not?
This is the same question in almost all the psychodermatology forums being asked, whether they can prescribe the psychotropic.
If they have a knowledge and they have know the pharmacology of the antipsychotic, why not? Why not?
Yes, sir. If they're confident, if they know anything, so then
yeah, sure.
Because I can prescribe an antihistaminic, then why can't they? So, but they need to know when to prescribe it, what dose and what to anticipate, and what can be the outcome. So then it's fine.
Most of the dermatologists do prescribe and then ask us this ठीक से लिखा है कि नहीं सर कुछ गड़बड़ तो नहीं होगा. They are do and then they call me.
Yes, sir.
Yeah, correct. We write antiphagals, they write anxiolytics and antidepressant. It's common practice. We do that.
A corollary to what you told. Another patient was tried on pimozide, aripiprazole, risperidone, but failed. Now what?
So you know the psychiatric cases also, like schizophrenia or delusional disorder. You are giving a lot of antipsychotic and they are not responding. So you go and try.
Yes.
You can't do anything. There are a lot of resistant cases in all faculty, and they are primarily psychiatric illnesses and not dermatological illness.
Okay. There's another question on I can take how successful is habit reversal training for itching in atopic dermatitis? So that's being tried in our center there where clinical psychologists go ahead with that. Even for trichotillomania or nail biting, etc., that's being done. So we have got good result, but we always combine with the psychotropic. First, not only just antidepressant, but most of the patients will receive medication plus therapy. So that gives better result when compared to either therapy alone or medication alone for us.
People have tried a lot of non-pharmacological treatment like biofeedback,
yes, sir.
like cognitive therapy, even hypnosis. Some people have tried hypnosis to treat what, you know. So they are reported in dermatological journal. We have not seen, but it hasn't been reported.
Okay. There is a question. Any comments about cholinergic urticaria?
Usually the antihistaminics only will help, sir. That's what even the literature tells, I think, about role is about antihistaminics, sir. Akhtar sir can help me in this question.
All urticaria are same. It is a cholinergic urticaria is because of some other reason. It is not because of, so probably only antihistaminics do help.
Yes.
You can't do anything more than that. You have to avoid the sun and other things.
Yeah.
So
only the triggers to be avoided.
There is pressure urticaria, there is cholinergic urticaria, there is a lot of urticaria. There is a psychogenic urticaria, you know. So
Yes.
urticaria is urticaria. Which is psychogenic, then you do hypnosis, biofeedback, and other things. In cholinergic, you do only same urticaria, and they are usually resistant to treatment.
Okay, there's a question. Can you throw light on lamotrigine, chlorpromazine, carbamazepine induced rash and lithium induced worsening of psoriasis?
Yes, we have cases, I mean, worldwide reported in case series, etc. So when there is a direct temporal
lamotrigine causes
yes,
it is not much, but there are reported of Steven Johnson syndrome
yes,
with
yes,
lamotrigine, carbamazepine. Rashes are common. You have to very cautious about prescribing carbamazepine, oxycarbamazepine, lamotrigine also for Steven Johnson syndrome. And when it comes to epidermal necrolysis also, we can toxic epidermal oxygen. So it do occur with these drugs. Psoriasis worsens with lithium, no doubt about that. And one thing that seborrheic dermatitis improves with lithium. So when we were working in CIP and prescribing lithium, and I was amazed to see that some of the seborrheic dermatitis improving with lithium. So there may be some mode of action of lithium was such that probably more. So we don't know. So some people were advising that lithium solutions should be prescribed for seborrheic dermatitis. It did not show the light of the day, but yes, there was some hypothesis about that.
Yes. Also, while choosing any psychotropic for our patient related schizophrenia, depression, or any of the things. So, as Alim sir was asking, what else we can think of? We can look at whether the person has any pre-existing dermatological condition.
Yeah, definitely. Yes, sure. Sure.
Question on lithium-induced acral dermatitis. What kind of presentation? How to diagnose? Should we discontinue lithium in this?
Have you seen cases of acquired dermatitis, lithium induced?
No, sir. At least I have not seen, sir.
I have not seen.
Yes.
Okay. Then we can give it a pass. Amrit, I think we have covered the questions.
Yeah, because he has spoken in large, he's covered a lot of issues. It's almost like a textbook he was covering. So give him some rest. We'll call him again for any details, anything.
Yes.
I think.
I think what Akhtar sir was suggesting, just the skin signs and how it is correlating with other diagnosis would be an interesting session.
Yes.
Akhtar sir, we need your help in that.
Okay, we'll see.
There is one question we can take, actually. Depression and anxiety disorder medications cause jock itch or fungal infection. I'm suffering from 3 years. This is a question that has come for the second time. So I just let us take the last question. The client was
Unlikely, sir, because unlikely it can lead to any fungal infection. Probably, I suggest like if any person has a fungal infection and then at an unusual age, either just check for sugars first. So that's what we are doing nowadays. So most of them have diabetes. Yes.
So
Fungal
chairperson,
infection is rampant these days, and they are very, very
Yes, sir.
resistant to treatment.
Yes, sir.
Even with itraconazole or other things, after 30 days or 40 days, they can reappear. So currently, the strains that is causing fungal infection is very resistant, and it is rampant.
Yes.
And association does not mean causation. If two things are
Yeah,
occurring,
sure.
Yes, sir.
Association does not cause.
So-
Mean as
take help of a psychiatrist and a dermatologist.
yes.
sir, closing remarks before we hand it over to the chairperson, sir.
I think it was a very nice presentation, and discussion was at its best, and so was the moderators. So moderator were also very pleasant, and I think such webinar are very fruitful for us and everybody who is watching this.
Yes. Yes.
Thank you, Adarsh bhai.
Thank you very much. I think I don't have anything more to add. Thank you.
Thank you, Tufan sir.
Thank you very much. First of all, I earnestly thank Dr. Adarsh Tripathi and especially Dr. Saeed Akhtar, who has been here after a long gap and after repeated requests. Thank you.
Thank you very much, sir.
It's nice seeing you.
Nice to see
And-
you.
And this is
Okay,
after this lecture, you can realize that really the interface between dermatology and psychiatry is quite fast, extremely fast, but really happens regular practice. Both the clinics are crowded. The psychiatrist does not
Yeah.
bother to ask about the dermatological manifestations. If he notices something, write something and send the patient. And send patient takes a circuit to reach a dermatologist or not known to him. Same thing with the dermatologist. Right? Most commonly clonazepam and most common antidepressant they are nowadays writing is acetaminophen. And they don't refer. But what is really required in future, every psychiatrist should have liaison and every dermatologist should have liaison with a psychiatrist. Consultation liaison is very much important in this. But thanks for eye-opening comments, eye-opening lecture. One question I was thinking that you will be speaking about dermatoglyphics. And we missed it because there are a lot of publications about dermatoglyphics related to schizophrenia, AUC, mental depression. And these are being researched since long. When we had been students, there are also old papers in dermatoglyphics. And they also pursue till do you take that into consideration? Or it is only of academic importance?
Yes.
Okay, thank you, Dr. Monoli. Thank you very much.
Thank you very much.
Thank you, sir.
We'll have another session definitely on this. As Dr. Akhtar my dear friend has suggested, and we'll take these things into consideration at that time. Thank you, everybody. Over to Amrit.
Sure.
Amrit,
On
Alim,
behalf
bolo
of
kya
the
bolna tha?
IPS Odisha State Branch, I would like to thank Dr. Ravindra Munoli, a close friend of mine. We always talk on the phone. He is a very, very good organization man, and I'm happy to know that he has put his focus on something which we generally don't put. And it was wonderfully covered. As Dr. Akhtar told, it was little, comprehensive, but because there are a lot of beginners, lot of people who are newly into these things, so it was required. So the moment this topic came, the thing became that the Syed Akhtar has to be the sir, has to be the chairperson. Skin clinics in CIP, that it was more, there were more people for the skin clinic in a psychiatry hospital than psychiatry patients on.
To my knowledge, he is the only person who is an expert and practices in both the fields.
So sir, his skin clinic was equal to his psychiatric clinic, and both were almost jam-packed always. So, and sir is able to maintain both the things. It's really wonderful. It's like keeping two wives happy at the same time. Is a rarity in this world. And that's what Dr. Sir has managed to do. Others was, I don't know, he has been quiet today. He's listening and observing more. And thank you so much. He's again a very, very dear friend. Thank you everybody for a wonderful session. Ali, Tufan sir again for guiding us, Torrent people, and we had more than 200 logins today, 220, 230 logins. And that's wonderful on in a puja where everybody else is doing puja shopping or people are having exams. So that's wonderful. Thank you so much, Dr. Ravindra. We'll call you again. Till then, good night. Have a wonderful weekend.
Thank you, sir. Thank you all.
Thank you very much.
Thank you.
Thanks, Ravindra bhai. Chaliye, sir, I'm closing the meeting.
Yeah.
Okay, good night. Thank you.
Good night.